It's a pleasure to discuss some advances in intraoperative imaging and guidance. I'll focus in on applications in intracranial neurosurgery and touch on really 3 cutting-edge technologies that were developed within a project in my group over the last 5 years. As Stuart kindly introduced, I'm a professor of imaging physics, radiation physics, and neurosurgery at MD Anderson. I also direct one of the focus areas in the Institute for Data Science and Oncology at MD Anderson, and that in particular includes surgical data science. Just a quick note of support and disclosures related to this work. The research that I'm going to focus on today was supported largely by a U01 from the NIH and conducted within my group previously at Johns Hopkins University. And so most or almost all of the work I'll show arises from that. And it includes biomedical research partnership with Medtronic. And so I think that's the only disclosure of interest as well there is relationships with Medtronic. So very broadly within neurosurgical image guidance, apart from interventional MRI, we're concerned with technologies related to imaging. That could be preoperative CT, preoperative MRI, the planning and trajectories and so forth associated with that image data, and also intraoperative, for example, cone beam CT. And everybody recognizes the O-arm in this photograph here. And so coupled with that are systems for navigation, either infrared, optical, and electromagnetic trackers, which are conventionally rigidly registered to preoperative imaging and intraoperative imaging as well. And finally, endoscopy. So in intracranial neurosurgery here, we're talking about a transventricular neuroendoscope. That could be freehand or robot-assisted, and is a valuable view into the surgical scene, of course, and can be used to deliver electrodes potentially via the working channel. Robots in this context provide an especially stable platform for tool holding, but could be used to do some other things, which I'll touch on here. So the 3 technologies that I'm going to discuss are those 3, and specifically using cone beam CT systems in a form where we hope to really advance the image quality associated with cone beam CT to a level that is sufficient to drive accurate deformable image registration of preoperative MR into the intraoperative cone beam CT in a way that accounts for brain shift deep within the brain. And finally, intraoperative 3D endoscopy, where we use the 3D information and registration described above to be able to augment planning structures directly within the endoscopic scene. So for example, this purple structure here was transformed directly from the preoperative MRI and is augmented into the video view and represents a structure that's actually beyond the visible scene. All right, so to get started, we all know cone beam CT. It's a technology prevalent for a couple of decades now in the operating room. And in cranial context, it's sufficient really for rigid registration, and that is to say bone. But beyond that, it conventionally faces a number of challenges. It's insufficient for deformable registration of intracranial structures, and it's insufficient to detect complications like a hemorrhage. The challenges to the soft tissue visibility there are numerous and are the study of imaging physics research ongoing. And the solutions are similarly numerous, include hardware, improved X-ray detectors, for example, and algorithms to correct the artifacts, invoke physics models for so-called model-based image reconstruction, and more recently, deep learning models, where we learn to restore image quality through many learned examples. And that's what I'm going to focus on here as a solution to image quality in this context. So let's look first at that physics-based, model-based image reconstruction that I mentioned. So we've got raw data here from the O-arm, numerous projections from the O-arm. We use physics models to impart artifact corrections. For example, X-ray scatter is a big one, but there are many. 3D image reconstruction methods go back to the dawn of CT, just 3D variations of what's called filtered back projection, or more sophisticated iterative reconstruction methods based on a physical model. And so work by one of my PhD students here, Pengwei Wu, really did a nice job of saying, well, we can push these physics-based models pretty far. Now you're starting to see a pretty major increase in the image quality here with just within one axial slice of a cone beam CT data sets, where we're seeing the ventricles pretty nicely. But there's residual shading and artifacts, and with metal in this scene, that becomes more challenging as well. Compared to a helical diagnostic CT, right, there are still real challenges to overcome. So with this about as good as we can do from a physics standpoint in cone beam CT, and these images down here show a clinical study that we did across 30 subjects under an IRB protocol. We can say, well, can we take this one step further and really, be able to get this to a level that's more consistent with a diagnostic quality CT, again, with our goal being to drive a deformable registration to preoperative MR. So that's where physics starts to transition to deep learning. And so one method for deep learning-based image reconstruction or image restoration uses a generative adversarial network, or GAN. So I'll show you a little bit about under the hood about how a GAN works. You see this a lot in various forms of generative AI. And in CT, it works something like this. We take physics-based reconstructions of an image as input, but we pair them with a diagnostic helical CT of the same subject. And you train a generator and a discriminator to be able to tell the difference between real or a synthetic image. And so there's a discriminator loss and a generator loss, and you iterate over this until, you look closely here, the synthetic image becomes more and more similar to the diagnostic CT. So you take away the discriminator, and now you're left with this system here, this GAN, that is trained to take input cone beam CT data, but produce a so-called synthetic image that looks very similar to the patterns that are learned by images in helical diagnostic CT. So there are numerous advantages to that. It's fast. You can adapt this to other scenarios. I'm just showing the brain here. The artifact correction, noise reduction, and even some resolution enhancements are very promising. The limitations, it's data intensive. A paired data set like that is nice, but can be a bit hard to come by. And there are other ways of training up on that. But a real limitation here is, to what extent can the synthetic image be trusted? Is it reliable, right? Has it seen abnormalities within the training set that it can reliably reproduce? For example, a tumor or some pathology. Right? It's difficult to have a good, robust training on all sorts of abnormalities that we would expect to see in surgery. Well, in order to know, well, can we really trust it? One good question is, can we estimate the uncertainty in this image? And if we can estimate the uncertainty in this image, let's say every voxel by voxel, the certainty with which this synthetic image represents reality, can we use the uncertainty to make a more reliable image? And that's what I've illustrated here. So here's just that generator again, cone beam CT data in. A generator produces a synthetic image like you're seeing here in the sagittal. Well, one way to produce an uncertainty map, to estimate the uncertainty in that synthetic image, is to introduce a so-called dropout layer, a Monte Carlo dropout, where basically now I can run this 5 different times, 10 different times, etc. Take the standard deviation over the synthetic image estimates, and that standard deviation is a proxy for uncertainty. There are some other ways to do that. This is work done by another PhD student in my group, Xiaoshuan Esme Zhang. And she showed that with this uncertainty map, you can do a mixing. So a little bit of math here, it's a mixing of 2 images, the physics-based cone beam CT image, the synthetic image, and you can see they're just weighted by this uncertainty map, this sigma, which I've just sort of rewritten as beta here. So you just mix the 2 images together in proportion to the uncertainty. So where the uncertainty is high, there's something in this image that we just never saw in training before, well, we'll go to the physics, right? We'll go to the raw data. It's something we know we can trust, so we'll bring that in. But in regions where the image is reliable, right, the uncertainty is very low, we'll use information from the synthetic image. So we refer to that as DL recon. And just some results of a clinical study shown here. On the far left is that very first image we said sufficient for bone imaging. Second column, probably about as good as we're going to get from physics-based, model-based image reconstruction, a synthetic image, an uncertainty map, and the deep learning recon. And we just zoom in here. There again, here, for example, you see pretty good visualization of, for example, this intraventricular hemorrhage. And you can see it's not quite accurately reproduced here in the synthetic image, right? This network wasn't really trained up to recognize abnormalities like a hemorrhage. But the deep learning recon starts to mix those two in a more reliable way. That method was actually best paper in the Medical Physics Journal last year. So that's one promising way of improving 3D intraoperative image quality. It's one that I would expect surgeons, if you're using the O-arm or some other kind of 3D intraoperative cone beam CT systems or interventional radiology, you can expect to see these kinds of advances in years ahead where no longer are these systems really only just good for bone imaging and rigid registration. So with that image, let's see if we can take things a bit further and transform the preoperative MR data and all of the planning that we've done there into that intraoperative context, courtesy of a high quality intraoperative image. Well, registering an MR to a cone beam CT image, as you can imagine from these two images that we're trying to deformably align, it's very challenging. But actually, we just talked about something that gives you a clue as to how we might do a better job of this. And it's that same kind of generator discriminator method where we could produce a synthetic image that is intermediate. For example, here, an intermediate image like CT, like we were just doing. So we can take the cone beam CT, create an intermediate synthetic CT, create the preoperative MR, create an intermediate synthetic CT, and now register these two. All right, so now the image intensities are a little bit more correspondent. So it's a little bit more reasonable question to ask to align these deformable structures within the cranium, but it's still tough. But about 5 years ago, a method referred to as voxel morph and referenced down here demonstrated a pretty good capability to use synthetic images, intermediate synthetic images, and deformably align them. So now this neural network is really intended to estimate this transformation, this deformation of structures internal to the cranium to align the image information. We did a variation of voxel morph called joint synthesis and registration, or JSR, where we simultaneously solve for this intermediate image. It turns out to be something like CT, but it doesn't have to be. It's actually an intermediate image that's optimal to the task of aligning these internal structures. So it doesn't just have to be a CT image. Actually, it can be a little bit edgier and so forth that assists the registration. And it simultaneously solves a transformation map, and it forces certain aspects of consistency between the synthetic image and the preoperative MR. So this is work by another PhD student in the group, Runzi Han. Did a nice job, and here this shows some example data where here's a cone beam CT images, and the green lines just represent gradient edges within that. Here, a preoperative MR simulated to show a very large deformation of the ventricular space, maybe sort of like hydrocephalus. And so now you see we've got many millimeters of deformable registration error between these two images. But on the right is the JSR image. Again, so following that transformation, we see close alignment of the gradient edges. And so now we've got, we've reduced that deformable registration error quite a bit. On the right just shows some quantification. So a rigid registration leaves you with many millimeters of error. A very good physics-based deformable registration, symmetric normalization with mutual information can do a reasonable job, but it's computationally expensive. Voxel morph by itself is fast, but then this joint synthesis and registration is similarly fast, reduces the registration error at about 2.5 millimeters, and improves the dice coefficient in the overlay of structures. All right, so I hit the gas a little bit, but we're almost to what we intended to achieve, which is to put those structures from preoperative MR right into the endoscopic scene. So here we've got high quality cone beam, deformable registration, and now we're going to bring those planning structures right through the transformation into a calibrated endoscopic video. All right, so no need to tell this group, but freehand neuroendoscopy is common in, for example, endoscopic third ventriculostomy, cyst drainage, transventricular placement. It could be done either freehand or increasingly with robotic assistance, which I think is a Even just using the robot as a scope holder is, I think, a nice advance in quality. That robot could be tracked, or it could just be freehand, as I'll show you in a moment, tracked directly from the endoscope. So here are some data with our colleague at Hopkins, that's Mark Luciano. And so you see the kind of freehand neuroendoscopic scene, beautiful visualization here in the lateral ventricle, looking down the foramen of Monroe, and you see the choroid plexus there along the bottom of the scene. So what we did is a clinical study in which we came into the operating room, set up a geometric calibration jig just to rectify the distortions of the lens and so forth, recorded freehand endoscopy, and we can bring those out into an algorithm, a computer vision algorithm for reconstructing a 3D view of that endoscopic scene from the natural motion of either the surgeon's hand or motion of the robot. So the methods for doing that 3D reconstruction are numerous in the computer vision literature. For example, SLAM is simultaneous localization and mapping. There's others, SIFT, SURF, NERF, that's neural receptive field, and so forth. And so by way of that 3D reconstruction, now we can track the position of the endoscope and therefore overlay positions from the MRI. And so here are results of a clinical study. Again, another 30 patients undergoing ETV or other neuroendoscopic procedures. They all have preoperative MR. We did automatic segmentation in those images using FastSurfer. It's a freely available deep learning-based segmentation tool. So now here we've got plenty of structures here. We did 3D video reconstruction using, actually here we're showing that reconstruction via neural receptive field. So this is the video. But what you're seeing here in the lower left, that's actually the 3D video reconstruction via this algorithm called NERF. It looks like the video scene, but it's actually just a point cloud 3D video reconstruction. So this is a 3D image you're seeing here. And now we map those structures through from the MRI through the deformable transformation. Remember that we computed based on the cone beam CT. And in that video now we can overlay these structures back into the actual video scene. So you see a few structures highlighted there. So just like augmented reality, I refer to this as augmented endoscopy, right? And what you're seeing there are structures beyond the visible surface. So you can imagine other applications of this as well. For example, in the skull base. So a transsphenoidal approach to the brain where you want to see behind the surface of the posterior sphenoid, the carotids, the pituitary, and so forth. Here it is in the ventricles. But really any endoscopic scene, this is the kind of capability that I would expect to see in years ahead. And I think it's a great application of augmented reality. And say this is also work by a PhD student in the lab, of course, Prasad Vagdardi, who's doing a great job with this work. All right, so conclusions and outlook. I tried to touch on 3 technologies that are emerging here within the brain context. Intraoperative image quality beyond the conventional limits of just being good for bone visualization, and the technology that's enabling that is physics plus deep learning methods. And that mixture is important to having not only a high quality result, but one that is reliable. Deformable image registration, here again, deep learning based deformable registration methods, really moving the bar on the ability to compute accurate deformable registrations, but very quickly. And finally, this business of augmented endoscopy, where either with freehand or robotic endoscopes, like you might hear more about the robotic side of things from upcoming speaker, Dr. Nobuhito Hata. That would be great. But this ability to visualize beyond the visible scene in endoscopy, I think, is very exciting. All right, so just to acknowledge the folks who put effort into this. The team at University of Texas MD Anderson Cancer Center includes David Jaffray, who heads the Institute for Data Science and Oncology. The Surgeoneering team, these are folks on my group now working on things like this. And at Johns Hopkins, where a lot of this work was performed under NIH support at the iStar Lab and Carnegie Center. The junior faculty who worked on that project, Craig Jones, Jung-Hoon Lee, Ali Uneri, Wojtek Zbiewski, and these all-star PhD students as well. Thanks very much.
Thank you. Before you get rid of that last slide, can you say a little bit what we're looking at, that funny looking helical structure that we're looking at there?
Thanks for asking, Alan. Well, at MD, or at the Texas Medical Center here in Houston, you're looking north across what is called the mid-campus. And so Holcomb Boulevard includes Methodist, MD Anderson, and the numerous other hospitals here that conglomerate at the Texas Medical Center. But this helix shape is a new development here across our mid-campus, and it is a translational research park for the Texas Medical Center. So the building right there, for example, is called TMC3, and that's where the Institute for Data Science and Oncology is set up, right there within arm's reach of this juggernaut of clinical services at Anderson, Methodist, and other partners.
That's actually where Pumps and Pipes is going to be this year on December the 9th, and tickets do go on sale this morning right now. We have had some really interesting questions coming from our audience, so I'm going to attempt to get through these. There's two I believe could get combined. So the first one is skull rigid, fusion easy, are you working in soft tissue deformity? That could be combined, I guess, with if skull is opened, how do you adjust for any change in brain structure?
Those are great questions, and it was really the purpose of that second technology that I was talking about, where if you can form a high quality 3D image with cone beam CT, and now you can start to see those soft tissue structures even after the skull is opened. There's pressure changes, there's volume changes, etc. But you've got a high quality intraoperative image of that. Then you can take the preoperative MR, ignore the skull, you can strip that or what have you, and now deform those intracranial contents onto that high quality intraoperative cone beam CT. Right, so not just the surface level brain shift, but the deep brain structures, which is what I was focusing on here. So yeah, so even though the brain is rigid and that fusion is straightforward, what I'm really talking about here is that next step of deformably registering the soft tissues. In other areas like radiation therapy, this is done every day, in aligning soft tissue structures of a planning CT to a treatment CT. But seeing it in surgery, I think, is coming fast.
Does MR elastography play a role in this at all, or could it play a role?
Great question. I think it might play a valuable role in understanding the kinematics and biomechanical properties of tissues, where elastography can give you some really viable, useful information there. And as another speaker this morning will talk about, Mike Miga at Vanderbilt, those kind of biomechanical models can bootstrap those kinds of deformation models even more.
Can I ask one final question, and that is, the way medicine was kind of built, there was imaging departments, they're called radiology departments, and then there were doing departments, I call them surgery departments. And the evolution that you're seeing, this is kind of where you're on the front edge of this, is starting to put the imaging in the operating room. Now, I think of the no-ring as being pretty crud. Hope I don't destroy the support, but we're now in a situation. I know they've got these at Anderson. We got MRIs in interventional rooms. We got CT scans coming, which is going to do nothing but make the fusion and the repeat imaging a little easier.
Yep.
What do you think is going to happen?
Well, I think there's a spectrum, Alan. It's a great question. Imaging is always about the task, right? And so imaging should be as good as necessary to accomplish the task. And so that spectrum could include the high-end, premium kind of installation with intraoperative MRI, intraoperative CT, et cetera, hybrid arrangements, and so forth. The Amigo operating room in Boston, right? So that high end of, cutting edge, very high quality intraoperative imaging. But there's a spectrum, right? Let's say mobile systems. Mobile MR has some really interesting new technologies coming as well. Mobile CT, mobile cone beam CT. And again, it's all about the task, right? And so you might even think that there are even lower end systems coming that are not suitable for diagnostic purposes, but suitable to a surgical task. They're enough for me to register high quality information preoperatively into that. And if it's just that diagnostic, if it's just that geometry problem that's being solved, some of these medium end systems are up to the task.
One final comment. I think you're right on, because we've kind of gone through this evolution in my specialty in vascular surgery, where first of all we fought for a portable C-arm, then we got portable C-arm. That got us in the game. Then we argue for hybrid rooms, but the portable C-arm technology and the imaging quality has caught up dramatically. And so the cost of building a hybrid room, probably $8-9 million. The cost of building a surgical room with a portable C-arm in it, a fraction of the cost, and it can be used for other procedures. So I think what you're doing with portable imaging structures is very important.
Thanks very much.
Thank you.